Hello, I'm Bruce Strober. I'm a clinical professor of dermatology at Yale University School of Medicine in New Haven, Connecticut, and I also practice at Central Connecticut Dermatology in Cromwell, Connecticut. Welcome to the next episode of our Innovations in Dermatology podcast entitled Next Gen Oral and Biologic Psoriasis Treatments. We're going to be exploring what's new and exciting in the therapy of psoriasis. And with me, I have Dr. Kenneth Gordon, who is the professor and chair of dermatology at the Medical College of Wisconsin in Milwaukee. Welcome, Ken.
Thanks, Bruce.
So we're at a really continually exciting time in the treatment of psoriasis. As many out there know, it's been about 20 years of renaissance in psoriasis therapeutics, including many biologic therapies and some small molecule therapies. And the hits keep on coming. We have on the launch pad some new agents that will be approved in the next 12 months, both of a topical and systemic nature, whether they're biologic or oral. So we'll be focusing on the next generation of systemic therapies for psoriasis in this conversation. So Ken, tell me a little bit about the IL-23 inhibiting class of biologics. Any updates in that department?
Sure, Bruce. Well, when you think about it, the anti-IL-23s, the three agents in the class, guselkumab, tildrakizumab, and risankizumab, have been around for a few years now. But what's really coming out that to me that is of significance is continued safety data and long-term safety data with these agents. And secondly, more information on psoriatic arthritis. From a safety standpoint, I think what's really not only impressive, but very reassuring is that the safety signals just don't seem to be coming. That's very concerning for these agents. Looking at long-term infection and cancer risks, there have been minimal changes that we've seen. From an efficacy standpoint, we've seen with all three of these agents sort of long-term continued efficacy that persists quite nicely. And these agents tend to have great length of response. But even more so, I think from an efficacy standpoint, we're looking at psoriatic arthritis as the key and the efficacy of these agents, which no one was quite certain if these would be significantly active, but guselkumab has been approved now for the treatment of psoriatic arthritis. So we expect the other two agents to continue their development programs to show some significant efficacy in psoriatic arthritis.
Yeah, I think that's really one of the major advents in therapy for the IL-23s is the possibility of use for psoriatic arthritis. Now, the IL-17 inhibitors, we have three already approved, brodalumab, which is an IL-17 receptor blocker, and then two IL-17A inhibitors, secukinumab and ixekizumab. They are somewhat forming the new gold standard for treatment of both skin and joints. So they are undoubtedly excellent choices for patients with bad skin and psoriatic arthritis. But what do you think about this new monoclonal antibody that's being brought to the fore, probably going to be approved by the end of the year, bimekizumab?
Well, bimekizumab is really interesting because it blocks both interleukin-17A and F as a monoclonal antibody, as opposed to brodalumab, which blocks both agents by blocking the receptor. And if you look at the efficacy, now there have been a number of papers published just in the last 6 months with bimekizumab. You see consistently high-level responses, probably higher than the other agents that we've seen, and there have been a lot of comparator trials that are extremely exciting. But even just as exciting is the concept that with an anti-IL-17 agent, it seems consistently that we can use bimekizumab at an every 8-week interval, as opposed to the every 4 or even sometimes every 2-week intervals we use for the other agents in this class. So you have very, very high levels of response, probably the highest levels with the fastest response we've seen. And you're seeing prolonged ability to prolong the interval of use of the drug, which is something that's a satisfier for patients. So I think those elements make bimekizumab extremely exciting. Additionally, there might be some really exciting data coming out on psoriatic arthritis, but that's still earlier in development. So we're waiting to see the true efficacy of bimekizumab, but early returns on bimekizumab for psoriatic arthritis are tremendously exciting.
Anything about this new agent that should be of concern? I know that candidiasis appears more frequently in patients treated with bimekizumab. What's your viewpoint on that particular issue?
I think it's going to be an interesting issue for clinicians. In my experience and what I've seen from the data, there are an increased number of candidal infections, almost all limited to the oropharynx, but there are occasional episodes of Candida coming into the esophagus. It's not particularly significant for the patients. Very few patients in the clinical trials have had to stop because of this. But it is a nuisance, and it's a relatively significant nuisance. And so the ease of treatment is going to be quite significant. How these are going to, if they're going to, or individual, is something that's going to be something that we have to understand. And it's still how it's going to impact clinical practice, I think, is still up in the air a little bit. In my practice, a lot of the patients who are going to require bimekizumab are severe enough that it's really not going to matter. We're going to just treat it and get through it. But I can see clinicians thinking that the nuisance part might not be something they use as first-line agent, though the rates of response and the speed of response is really quite impressive.
It's definitely one of those issues we're going to have to follow and how it plays out in the real world, because many of us probably have no problem treating oral candidiasis. We'll have our playbook. It's just going to be, to what extent does it create a burden on the practice? Now, the other issues that we associate with IL-17 inhibition, such as inflammatory bowel disease as a potential risk, either flaring current IBD or de novo development of IBD, that doesn't seem to be as big an issue or an increased issue with bimekizumab, unlike the candidal issue. Do you agree with that?
Yeah, I think the IBD issue is something that is a bit controversial, and I know different people have different perspectives on it. With bimekizumab, there is potentially some theoretical reason why it'd be less of an issue if you block interleukin-17F. But the clinical data will bear out the real answer, and we don't have enough clinical data to really judge that yet. I sort of view the inflammatory bowel disease issue sort of like we used to view multiple sclerosis with anti-TNF agents. It can happen. You don't want to use it in people who have active disease or probably even a history, but it really doesn't come into play in people who don't have a prior history of inflammatory bowel disease. And Bruce, I've talked quite a bit over time. Though there are trials with Crohn's with both brodalumab and secukinumab, many of these events are in patients with ulcerative colitis. And I think we have to keep in mind that we oftentimes associate Crohn's with psoriasis, but the patients who are coming up with the IBD flares, oftentimes are ulcerative colitis patients. We just always have to keep that.
So to summarize bimekizumab, very high efficacy, probably the most efficacious and fastest drug we'll see to date for psoriasis. Q8-week dosing is likely, so a very unique infrequent dosing for IL-17 inhibition. Increased incidence of candidal infections, primarily oral candidal infections. Otherwise, a profile that looks just like other IL-17 inhibitors from a safety and tolerability standpoint. Now let's move on to oral systemics that are coming on board soon. Deucravacitinib, a specific TYK2 inhibitor that targets only TYK2 and not JAK1, 2, and 3. And the data are pretty firm on that. Do you feel deucravacitinib is going to be a breakthrough drug as an oral small molecule, Ken?
Well, I'm excited about deucravacitinib for a few reasons. First of all, mechanistically and the design of the molecule really makes it distinct from other members of the JAK inhibitor family. And I think that as we see development and use of the medication, we have to keep that in mind. It's not binding JAK1, JAK2, or JAK3 because of its unique nature where it doesn't bind the binding site, where pretty much all the other JAKs have cross-reactivity through the whole family. So this is really a TYK2 specific inhibitor, which means that a lot of the side effects that we associate with JAK inhibition, be it multi-organ toxicity, even though not a big deal, but something that we are concerned about, isn't as big an issue, though we still worry about infection risk in any time we affect the immune system. Efficacy-wise, it's good. It's not great. It's not biologic level efficacy for any of the anti-IL-17s or anti-IL-23s, but it's actually good, and it is a step up in efficacy from our oral medications that we've had in the past. So I think with the idea that you don't see a lot of multi-organ toxicity, including liver function test abnormalities or renal function abnormalities or lipid abnormalities, that's a great advantage. And I think that the efficacy gain you have is impressive and will make a pretty big significant difference in our use of orals within the dermatology clinic.
I agree. I think deucravacitinib, once daily, respectable efficacy, probably no need for laboratory monitoring. It might be somewhat of a groundbreaking oral medication that changes the way we treat all types of psoriasis. Now, moving on, JAK inhibitors for psoriatic arthritis. We've had tofacitinib. We're likely to get upadacitinib. What do you think the impact of these drugs will be on psoriasis therapy?
It's really difficult to say. So tofacitinib's been around for a while. There was a whole development program in psoriasis, and it showed some decent effect and worked in psoriatic arthritis reasonably well. Upadacitinib is a really interesting molecule. As we all know, it's been tried in atopic dermatitis and has been extraordinarily successful in the treatment of atopic dermatitis. Not yet approved for psoriatic arthritis, though it is approved for rheumatoid arthritis. And actually, if you look at the data in psoriatic arthritis, it's quite significant. But if you think really look at the data, it probably is going to be a highly effective medication for the skin portion of psoriatic arthritis patients as well. So I think dermatologists can have some experience using upadacitinib because of atopic dermatitis. And I think that might carry over into treatment of psoriatic arthritis and concomitant psoriasis as well.
Totally agree. I'm very impressed with upadacitinib psoriasis efficacy. Apremilast for mild to moderate disease. So apremilast has been studied in many different domains. And now it was studied in patients with 2 to 15% BSA, 2 to 15 PASI. And it basically has the same efficacy in that lower severity class of psoriasis patients as it does in what's called moderate to severe psoriasis. Do you think a label change for apremilast, which is probably going to happen, allowing us to treat lesser severity psoriasis is going to be very impactful on the specialty?
I think it's a wonderful concept, and I'm really excited that the folks who make apremilast went into this area. I think you have a large group of patients who might not have 10% body surface area who have very impactful disease. And so I'm really hopeful that the apremilast data and the change in the label will begin to get people thinking about treating patients with less body surface area involvement, but having very impactful disease. The rate of response with apremilast is about what it was with more severe disease, probably what we would have expected. But I think this is groundbreaking and hopefully moving the specialty to really care for patients who have very impactful disease in a more aggressive nature, which I think is good all around for our patients.
Totally agree. Now, getting back to TYK2 JAK inhibition, one issue that has come up, especially in the rheumatology world, is the risk for venous thromboembolic events. What's your perspective on that particular issue with regard to this class of drugs?
So to date, the thromboembolic events have been primarily associated with tofacitinib. Now, that might be because of a number of things. One is just how much the different JAKs that tofacitinib is hitting. It might be mechanistic, or it might be just the fact that tofacitinib has been used more often because it's the oldest of these agents. So I don't know what that's going to be. I don't see any reason to believe that deucravacitinib will have the same issue. Not in the clinical trials we've seen before, but I think we just have to wait and see. It's a significant problem, but it's very, very rare. It is dose dependent. And I actually had a patient with palmar-plantar psoriasis and horrific psoriatic arthritis who was on tofacitinib who had a thromboembolic event. And after doing a survey of many folks, the thought was, let's decrease the dose, because it was the only thing that helped them, and continue the therapy and, with, mild anticoagulation. So it's going to be something that people have to get used to. But it is something that is potentially traumatic for the patient. So, is it going to affect the entire class? I have no idea. But something we have to pay a lot of attention.
And I use a lot of JAK inhibitors too, and I have a firm respect for them, and partly because of this reason, partly because I think they create more of a zoster risk. And so my point with JAK inhibitors will always be, you're always going to want to use the lowest dose that's still effective for the patient. It's not like biologics where we feel you could even dose higher than the approved doses and still be fine on a safety level. But with the JAKs, I'm always going to try to get down to the lowest dose and maintain patients on that lowest dose for this reason.
I think from an infection standpoint as well, since they affect the immune system somewhat diffusely, I agree with you. But I have to say, Bruce, and I think you probably agree, that on certain conditions, palmar-plantar, and certain patients, there's really no substitute for the JAKs.
No, there isn't.
Certain patients I cannot get better except with JAK inhibition.
Totally agree. And we can conclude with the comment that I think palmar-plantar psoriasis and maybe other types of psoriasis, you'll only have the JAKs as your best option, and biologics aren't going to cut the mustard. So we're going to end here by talking about how this is really a continuing incredible renaissance in dermatology, particularly around psoriasis, but also I think some of these therapeutics will have huge benefit for other disease states that we have also treat. And so if you're practicing medical dermatology now, you should appreciate the era in which you are practicing and living is incredibly unique. And actually a lot of other specialties look to us with envy with regard to how many tools we have at our disposal to treat severe, and now we learn mild to moderate skin disease of a variety of types. So Ken, thank you very much for this amazing discussion. I wish we had more time to continue it. I thank everyone for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.